Today's topic is measles. The reason why I chose this topic is not only because it's so much in the news these days, but also while I was on my call, TGH call, I got this page around, I think, 2 o'clock at night, sending me pictures of a rash. And they were initially worried about zoster, but um, as the conversation went on, I said that does not look like zoster. So then they were like, could this be measles? And I'm like, if it's measles, then the only thing that we can do at this point is just put on precautions, and then we can come in and evaluate the patient tomorrow. So this can happen to any of us, while we are on call or in patient rotation. So that's why I picked this topic. Moving on to the next slide, I just picked a case of adult measles. Obviously, what happened in this case is not something that's just the only thing that we will see. We can see complications. We can see, where the condition can self-resolve. So it can vary. This is just a simple case that I picked up to show that measles is not just only limited to kids, but we can see as in adult medicine as well. So this is a case of adult measles. 40-year-old male patient, no significant past medical history, presented with high fever, fatigue, cough, sore throat, conjunctivitis, and diarrhea. 3 days before developed an erythematous rash. He did get measles vaccine as a child. So let's see what it led to. So physical exam, notable for erythematous oral mucosa. They didn't see pathognomonic of measles, the Koplik spots, but saw some erythematous oral mucosa that would bleed easily, in addition to acute conjunctivitis and generalized maculopapular rash. Lab findings included thrombocytopenia, hyponatremia, and some increase in C-reactive proteins and increased transaminases. They went ahead and checked for anti-measles IgM antibodies that were positive in serum probe, and also measles virus RNA was detected from the oral swab and also in the urine. X-ray of the lungs suggested atypical pneumonia. In subsequent slides and during the course of the presentation, I will touch on all these points where I will talk about, the physical exam and how we diagnosed and why it's important to get this X-ray of the lungs. In terms of management, this patient was immediately isolated and symptomatic therapy with IV infusions just to correct the electrolytes derangements was done, and mainly he was given some medications for pneumonia. This case is from Germany, so that's why the medications are different from what we use here. The patient achieved complete remission within 12 days. So why this topic matters to us? Measles was declared eliminated in the US in 2000s. However, because of declining vaccinations, some hesitancy with vaccinations and global travel, I would also say that maybe because of COVID, there was decline in vaccination overall, so that also added to this. Adults, so that's why we saw a resurgence due to all these factors. And adults are at high risk of complications as compared to children. So that's why this topic does seem like important that I should bring it up. As far as the overview, we have in this presentation, I'll start with the history of measles and then talk about virology and transmission, clinical signs, diagnosis, complications, which seem like it's in adults, we see more complications or in immunocompromised patients. Clinical features in adults and management, in addition to travel medicine and some prevention and post-exposure. So starting with history of measles. So going way back 1910 AD, this was described first by a Persian physician, um, Razes al-Razi. So it seems like he was the one who actually described it way back in 1900. I mean, 910 AD. So before, oops, I don't know why my slides are jumping around. So in 1657 is when measles was first noted in Boston. So there was a physician, John Hull. He wrote in his diary that disease of measles went through the town, but fortunately there were only few deaths at that time. Sorry. So fortunately there were only a few deaths. In 1757, the infectious nature of measles was really described when a Scottish physician, Francis Home, he told us about how transmitted measles from infected patients to healthy individuals via blood. He demonstrated by injecting from infected patients to healthy individuals, demonstrated that disease was caused by an infectious agent, which obviously cannot be done now. But at that time, he was able to show this. 1954 coming on, Thomas Peebles, another physician, he was working in a lab at Boston's Children's Hospital, and he isolated the measles virus for the first time. Peebles, he learned of an outbreak at a private school outside of Boston, and after he got the permission from the principal, he collected blood samples and from 6 students, and that's how finally, he was able to. On February 8th is when he was able to succeed isolating this virus. Eventually, with all these advancements, with the measles virus being isolated, that led to development of a series of vaccines. So before the vaccine was created, we know there were a lot of deaths that were happening, which were also noted in 30 million cases of measles, with more than 2 million deaths occurred each year globally. And then comes in 1958, that's when the first measles vaccine was tested. So the physician Sam Katz, Dr. Katz, is an infectious disease specialist who was working with Thomas Peebles, MD, and other researchers in Boston lab. They were the first ones who really tested the first versions of the lab's vaccine. So in 1971 is when we see MMR combination of vaccines debut. That's when it came on and people were starting to get vaccinated with it. We did see some outbreaks. Obviously, there was one in 1989 where low vaccination rates led to outbreaks. But over the period from 1989 to 1991, there were measles outbreak that really sickened, and then the vaccine comes on, and we gradually see how vaccine really caused a gradual, or it's not quite a gradual, but I would say like kind of precipitous, like from 1965 and then 1970, we see how the reported measles cases in the United States from 1962 to 2023, they came down. And then around 2000, like I said previously, elimination was declared. However, even though by 2000 we had achieved elimination, which technically means that there is no measles spreading within the country, and new cases are only found when someone contracts measles, let's say abroad, and returns to the country. So that's what officially being eliminated from the United States meant. In Even though we had it eliminated, there were certain anti-vaccines group that continued to postulate MMR vaccine may be a cause of inflammatory bowel disease and autism. So this was all coming up in around 1998. They were saying that this vaccine could be related to autism, even though later on the paper that brought this was retracted, but it did cause anti-vaccination groups to pop up. People were more hesitant to take their kids to get these vaccines. And that really led to, unfortunately, now that we are seeing rise in measles cases, also disruptions in routine healthcare during COVID-19 was also one of the causes, I would say, not the only, but yeah. So in 2024, the national two-dose MMR vaccine rate in school-age children was 92.7, and state vaccination rates varied widely from 79.6 to other states 98.3. So it really varied from state to state. Looking at the map of measles, if we focus on this area, so Texas, obviously we didn't.
That's the problem when I left.
So yeah, it does correlate with the states. As you can see, Texas is one of the states where measles cases are one of the highest, and that does correlate with the vaccination hesitancy. So here are just a few snapshots of what's in the news. Pretty recent. So this ABC News, this is from May 16, 2025. Measles cases reach 1,024. And we've been seeing this for, I would say, like since 2000, starting, 2014. Then again, person vaccinated. This gives us an idea of where people are more likely to get their kids vaccinated or themselves vaccinated before they venture, to measles outbreak areas. Moving on to virology and transmission. So measles is as we know, potentially fatal, but it's vaccine preventable disease, right? So there have been a lot of work and research that has led to us understanding how the measles virus looks. So it's a structure of measles virus. It has an RNA genome, which is encapsulated by the N protein, forming a helical ribonucleoprotein complex that is associated with the viral RNA-dependent RNA polymerase. And as we can see here, there are fusion proteins and hemagglutinin protein, which really helps the virus to bind to the host receptors. Not going too much into detail, but that's how the virus attaches to the host cell, and then there's mRNA synthesis, viral mRNAs generated, and that's how the transmission really happens. So this is a slide that, or rather, the next few slides, I will talk about how infectious this virus is. So this virus is very hardy. It can be in tiny droplets and in the atmosphere, and it can linger for what I read for a couple of hours. So even after someone has left the room, you can still contract this virus. It's obviously airborne, as we know, is aspirated. Once it's aspirated into the respiratory tract, it infects alveolar macrophages or dendritic cells. Using the signaling lymphocytic activation molecule that was in the previous slide, the SLAM protein, and that's how it really, infects the lung macrophages, and how we would know, eventually it can also cause complications, including pneumonia and other respiratory tract infections. So just to give it a perspective as compared to other viruses, how contagious measles is. Number of people that one sick person will infect on an average is called R naught. So if we look at R naught for measles, it's 18 as compared to R naught for SARS or HIV, Ebola. So definitely this is one of the most contagious viruses that we know of. So estimated R naught for this virus, 9. It can vary from 9 to 18. So it can really infect up to 12 to 18 in contrast to other viruses. And that is why community immunity comes into picture, like why this is really important in the case of measles. So looking at this image, if let's say no one is immunized, and this disease, which is so contagious, infecting from one person to like 18 other people, contagious disease can spread through the population really quick. Contrasting it with some of the population that gets immunized, so we can see maybe not so bad, but once you achieve about 90% people that have been immunized, the spread of this contagious disease is really contained. And that is why we need herd immunity, and we need more and more people to realize how important vaccination is. This is again another image that tells us how herd immunity works. And so measles herd immunity threshold ranges from 89 to 94%, and which is basically related to its estimated R naught value. And this is all done by analytical models of infectious disease dynamics. So that's why we know that for measles, the herd immunity threshold has to be at least 89 to 94% for it to be contained. In terms of its clinical signs, I think we know about this already from, so measles has very characteristic clinical signs. One, fever, then rash, also conjunctivitis, and Koplik spots. Koplik spots is very pathognomonic. What we do also know is that the infectious period of measles is from 4 days before the rash onset to 4 days after the rash onset. And the pathophysiology of measles, again, this slide is tying the clinical signs with the prodromal phase and fever, rash, transmission, how the clinical signs can appear in immunosuppressed patients, to when the replication starts in the myeloid and lymphoid tissue. So measles infection starts with an incubation period, which is where the virus is replicating. And that's why we have the myeloid tissue, lymphoid tissue up there. And the time of infection, which I will talk about in the next few slides, there's an incubation period, prodrome, exanthem, and recovery phase. So these would be the stages of infection. Moving on to the incubation period, which is the first stage of measles infection. Incubation can last from 10 to 14 days from exposure to the first symptom appearance. And like I mentioned in the previous slide, where we have the virus, replicating in the myeloid and lymphoid tissue, and that's how it's disseminating via the viremia that it has led to. Then the next slide talks about prodrome. So prodrome it can last anywhere from 2 to 4 days with fever. We can see malaise, anorexia, but we can also see in this phase the 3 C's, cough, coryza, and conjunctivitis. And one of the pathognomonic, like I said, is Koplik spot. But the case that I picked up, that case in the beginning of this presentation, that case did not have a very characteristic Koplik spot. They just had oral mucosal erythema with easily bleeding mucosal surface. So it may or may not be there. So just to keep in mind. Koplik spots are small bluish white plaques on buccal mucosa, and they are present in up to 70%, but when they are present, they are pathognomonic. Moving on to exanthem phase. So in this phase, it can last from anywhere 6 to 7 days, and maculopapular rash is what is noted in this phase. It can also be associated with the lymphadenopathy and respiratory symptoms. Fever, obviously, fever can be even in the prodromal state, but it can be associated with other symptoms as well, like respiratory symptoms, pneumonia, and other complications as well. And then the final stage where recovery is what is noted after 7 to 8 days. It seems, as far as the literature goes and what we have seen so far, improvement does start 48 hours after the rash. However, it can have, other symptoms like cough that can be there from 7 to 14 days after resolution, and fever can be beyond day 3 to 4. In terms of diagnosing measles, so who should be really tested? There are certain algorithms out, in the literature that does talk about how we should be keeping these 3 things in mind. One, clinical symptoms, how the patient is looking. Do they have fever? Do they have rash? And where did the rash start? Also, susceptible patients. Are we looking at immunocompromised patients? Are we looking at adults who are, older than a certain age? However, adults above 20 is what we do consider as the susceptible patients. And then epidemiological link. So whether the patient has just traveled from an outbreak area, or they live in a state where the vaccination is not, that prevalent, or people are hesitant. So that's something that we have to keep in mind and test for the patients who we think that they do fit that criteria. And they could be someone who may be infected with measles. Looking at the timeline of a typical measles infection is what can be correlated to how we would be ordering our tests. So urine sample for RT-PCR, throat or nasopharyngeal swabs, also oral fluid samples. So these are all, as we can see, around like around 14 days or so, so around the incubation period. After that is when IgG, IgM, and antibodies can be detected using ELISA. They can be. I mean, you can order that, but that's when it's most likely to come back positive if the patient has it. So viral RNA can be detected in oral fluid samples for a maximum of 3 weeks, and IgM antibody, as we know, acute infection. So IgM appears shortly after rash onset, and IgG usually develops later, and it can persist for a long time. This is just a comparison of all the diagnostic tests. RT-PCR for acute infection, and then again, IgM, IgG, past or acute infection, IgM more for the acute infection. They can also be false negative risks, depending on whether the patient was previously vaccinated or sample was taken too early or taken too late. So that's why I wanted to show the slide where timeline of a typical measles infection is shown. Again, moving on to the complications. So some of the common complications, as we know, in measles is, at least in children, we know more about the otitis media, bronchitis, pneumonia, stomatitis, diarrhea. But needless to say that can also be seen in adults. Children under 5 years of age, they are at high risk, and adults above 20 years of age. So we can very well see these patients during our, inpatient work. And other patients who are at risk are malnourished individuals, pregnant people, and immunocompromised. In addition to these common complications, there are severe neurological complications, which obviously we need to keep in mind. Acute disseminated encephalitis. It can also lead to just post-infectious encephalomyelitis, also subacute sclerosing panencephalitis. So just to give a brief idea on SSPE, subacute sclerosing panencephalitis, this is caused by persistence of measles virus in the central nervous system, and it's a very slowly progressing infection, and demyelination really affects multiple areas of the brain. So some of the symptoms that we can see associated with it could be anywhere from behavioral disorders to psychiatric problems. So something to just keep in mind that these individuals can show, all these neurological complications as well. And then the complications that are associated with measles infection, this is really the percentage of how many has been, like how much of otitis media is, like 7 to 9% of patients have been noted for otitis media, then pneumonia about 6%, diarrhea 8%, and very rare, but still some of the deadlier complications, post-infectious encephalitis and obviously death. So increased risk of complications, like I already mentioned, some of the people who might be more at risk. Children in developing countries, because of the undernutrition and overcrowding, and they don't have much access to care, that can also cause higher mortality. In pregnancy, we can see other complications like miscarriages, preterm birth, and also maternal death as well. And in terms of the clinical features in adults, because that's what we will be seeing mostly. So, like I said, we can see obviously high fever, we can see conjunctivitis. So pretty much the similar clinical symptoms, maculopapular rash. What we do need to ask our patients whether they receive vaccines or not, and whether they went to those areas where they could be measles can be more prevalent. In adults, we also have noted longer duration of lymphopenia after measles as compared to children. So in terms of management, really the first thing that we do is supportive therapy. We isolate the patient, but the first thing that is to be offered is supportive treatment, because there's no specific antiviral medications that is available to treat measles. We could give antibiotics to, let's say, other symptoms or complications that might be happening in terms of pneumonia. We could give antibiotics for that, but as far as measles, treating measles, there's no antiviral, basically. There have been some studies that are coming up for certain antiviral, which I will talk in the next few slides, like in later slides. But as of now, patient management includes three things: isolate the patient for airborne precautions, and then supportive treatment. Also monitoring for any neurological complications. Another topic which is a little bit, controversial, or there have been talks whether to give vitamin A during measles or not. So I looked into that, and it seems like vitamin A deficiency is associated with adverse effects. So we do want to correct that. We don't want patients who do have vitamin A deficiency to just, we need to correct that based on the literature. So it does, I wouldn't say it helps, but vitamin A deficiencies affects delayed recovery. It affects, it causes higher morbidity and higher mortality. So it's better to, err on the side of just giving the vitamin A. It would not prevent measles, but at least the vitamin A deficiency can cause higher morbidity and higher mortality, which can be corrected if we give them vitamin A. So this is not only I noted it on the CDC's website, but also WHO does recommend in places where you see vitamin A deficiency, just give it to them. And then the most important thing, recommendations for measles vaccination. So first of all, in children, 2 doses prior to school entry, which we will not be seeing this, but at least in adults adults who have pre-existing immunity, but they meet one of the following. So if they were born before 1957, or if they have documentation of measles vaccination after 12 months of age, they have evidence of immunity or lab confirmation of the disease. So it's better to give them this vaccine. obviously born before 1957, like I mentioned, doesn't really relate to healthcare personnel. We do give them. Um, in terms of the vaccination, this is a live attenuated virus that does cause immune response. So we have to be mindful of some of the side effects. Vaccination side effects can be anywhere from tenderness, short fever, transient rash, and to like really extreme rare cases of anaphylaxis. Some of the contraindications, pregnancy and severe immune suppression, and also allergic reaction. Let's say if they had an allergic reaction. There's no component of egg or anything there. So obviously like as compared to the flu vaccine, so there's nothing that can um, from that standpoint. Um, in terms of the antiviral agents, like I was mentioning, there is ribavirin and interferon. A few cases here and there that they have reported how these agents were tried in severe cases of measles. However, overall randomized controlled trials are really lacking in this case. Um, it's not licensed by FDA for the treatment of measles, and it doesn't. There's still further research that is needed to determine the benefits of this antiviral. And then travel medicine. Um, so who is really at risk in terms of people who are coming to us in travel medicine? Um, who needs to be vaccinated? People who are not fully vaccinated. They can be they didn't have measles in the past, so they didn't have acquired immunity. Then people who are traveling to domestic or international areas where we know measles is spreading. So those would be the people who are at risk. And this slide just talks about how vaccination prevents loss of immune memory. So even if they had a vaccine, they can be, loss of immune memory. So not a bad idea to give them a vaccine if the titers are not detected. So if the patient is planning to, let's say, travel to an endemic area or where there's measles outbreak is going on, they should plan to be fully vaccinated at least 2 weeks before they depart. And if the trip is less than 2 weeks, then at least they can get, one dose of MMR. Although 2 doses have been, always recommended because 2 doses provide more protection. It provides 97%. However, giving at least one dose gives them 93% protection. And they should also watch for signs and symptoms once they come back from such an area. Um, so at least watch for 3 weeks after they return back. And some of the, like I've listed down recommendation for travelers, what we should be telling the travelers traveling to outbreak areas, 2 doses of MMR vaccine, and then they can also check CDC website for other travel related guidance and watch signs and symptoms. So post-exposure prophylaxis for measles is also out there. In terms of who should receive post-exposure prophylaxis, people exposed to measles who really cannot show that they have adequate immunity, they would be the ones who would be offered post-exposure prophylaxis. So there are two types of PEP for measles. One, MMR vaccine, which should be administered within 72 hours of initial measles exposure. And then the other one is immunoglobulin. which should be administered within 6 days of exposure. And this is the recommended dose of the immunoglobulin. And it doesn't matter, this is regardless of the contact's immune status, is what it says. So the dose is really stays the same. And to just give some clinical pearls, suspect measles in people who have febrile illness and rash, in addition to the 3Cs. So, like I said, I was on call and I got this. I was just sent a rash. Um, so I know, like, this was very premature to think that just based off the rash that was only in the buttock area to say that, yeah, that could be measles. But we we should always keep in mind that if the patient does have febrile illness with rash, and where the rash really starts, it starts on the face and then goes travels down, to the trunk, limbs. So something to keep in mind. And then especially in patients who don't have documentation of measles vaccine, we know that they are coming from overseas where measles outbreak is there, or there's lack of vaccination. They are coming from a community with low vaccine acceptance, and then also emphasize the importance of measles vaccine and be cognizant of the severe adverse events after the MMR vaccinations, um, which is rare, but it's actually, so what I wanted to say is that adverse events after the vaccine, they are there, but they are rare as compared to when you actually catch natural measles infection. So it's better to get vaccine, um, and protect yourself. And these are the references, and thank you so much.